Okay. All right, so today we're going to talk about cognitive behavioral therapy and give you sort of an overview, let's see, of specifically under the umbrella of CBT, relapse prevention interventions. So we're going to talk about triggers and trigger identification, urge and craving management, behavioral contingencies, and specifically how to talk with your patients about monitoring high-risk situations. So hopefully this will be some more concrete examples of things that you can do, and some of these can be done in anywhere from a general hour-long session, and I'm going to show you what a traditional CBT outline would look like, or you can take some of these components and just do them in 5 to 10 minutes if that's all that you have, if that's what you're choosing to focus on in that moment, and would still fall under the umbrella of CBT and relapse prevention. So go over some concrete stuff. The first thing I want to introduce, and we've talked about this before, is the stages of change model. So when you've identified that your patient is in a place where they've sort of moved, and this can be done both in the action stage but also in the maintenance stage, that's where we're going to be really hitting folks with relapse prevention, because that is what it means, right? We want people to be preventing relapse. You can get them started on a lot of these skills once they're in the action stage. So that means that they're ready to take positive steps in their life. So if we look kind of at a different model that overlaps with the stages of change, sort of how we identify somebody wants to stop using, that's when we're going to implement some harm reduction. Basically, how can they be as healthy as they can be today, and what are they willing to do to move in that direction? That's where we might also be using some of our motivational interviewing skills. But then once we're ready to do the active work, both in action and moving into maintenance, that's where CBT has a lot of evidence and really is kind of our heavy hitter and a good go-to for helping folks make positive change. And then once that change is pretty solid, then just enacting these relapse prevention skills as part of like ongoing recovery tools. So it's kind of the big picture how we can tie that together. Now, what is CBT for those of you that might not be that familiar? It is a form of talk therapy that helps patients to understand the links between their thinking, their emotions, and their behaviors. It has very good, clear evidence for treating addiction, and in fact, it's got some of our strongest sort of gold standard clinical studies that have shown efficacy regardless of the type of substance that a person is using, and good efficacy for people that are duly diagnosed. So they have a mental health condition in addition to their substance use disorder. It, like I said before, it's highly flexible. You can implement it in many different settings. You can use a manualized protocol that you would do specific things in about a 50-minute to 60-minute session, typically for about 2 to 3 months, weekly sessions, or you can break it into the specific interventions that we're going to talk about today and utilize some of those as part of your standard of care in whatever time that you have. The nice thing about CBT is this really is an education focus that empowers patients to become experts in their own symptoms, to understand their thinking, their emotions, and their behaviors in a way that they can start to intervene really without much guidance from you once they understand these skills. CBT can be applied very effectively, and in fact, it has good efficacy when used within the MAT header, because we know that folks will come in the door seeking medication and will oftentimes continue to come back because they're seeking the medication intervention. And so if you can apply some of these CBT skills while working with them, that you could kind of really impact their prognosis. So CBT stands for these first 3 components. Essentially, something happens in the environment. There's a trigger that affects the person's thoughts. So they have a certain perception of that trigger. Then that affects bidirectionally the emotions that they feel how their body responds to those emotions, and then the behaviors or the outputs that they put back into the environment. So a good example of this is, and some of you might have experienced this on your way to work this morning, when you're driving on the highway and somebody cuts you off in traffic, right? That's the trigger. Something happens. We have an automatic perception of that event. Most of us are probably like, what the hell, that jerk cut me off in traffic. That's our thought. The emotion that goes along with it would be something like an initial sort of fear or shock, followed by anger, which has to do with the how dare they kind of thought. We have a physical response that's connected to that emotion. That physical response in this situation would be something like elevated heart rate, maybe a surge of adrenaline or cortisol because they jumped out in front of us in traffic. And then we engage in a behavior, which if we're angry is probably we're going to step on the accelerator and maybe say some choice words or possibly tailgate, right? So that's one CBT cycle. Alternatively, we could have the same trigger happen, right? Person cuts us off in traffic. But if we have a different thought, we have an alternative thought like, oh no, I hope they're okay. Or I wonder if that person is having an emergency. That's a very different thought, which is going to elicit a different emotion, probably something like compassion or concern. We're going to have a different physiological reaction. Probably our heart rate isn't going to escalate as high. We're not going to have that same surge of cortisol or stress hormones. And then our behaviors might be very different. So we might actually slow down to give them space, or we might change lanes because we're concerned about the unpredictability of their behavior. So understanding that these things are all interconnected is one of the main things that we're teaching patients, because what we know we can't necessarily intervene at is the level of emotion and physiological reaction. Those things we tend to be not that helpful at changing. What we can change are the things that we think and the behaviors that we engage in. And so the crux of CBT is helping empower patients to be effective at slowing this cycle down, to be able to make those changes and transition from that automatic response of that jerk and then tailgating to, oh no, I hope something's okay, and being able to slow down. So that's essentially what we're trying to teach people when we're utilizing any form of CBT. Now, these tend to be highly structured interventions that allows the clinician to be relatively active. This is not a passive model of treatment. Most sessions are 60 minutes, and they're divided into 20-minute sub-sessions. So if you're doing a traditional CBT session, I'm going to show you how you can divide that into 20-minute subunits. Even though the clinician is fairly active or takes somewhat of a coaching stance, it's still important that we understand the stages of change and really the heart of having acceptance for where a person is, and that we balance not being overly directive or too passive, right? That we kind of want to strike that nice sweet spot in between where we're really encouraging, but also accepting that people kind of go at their own pace. So within that 60-minute session, we want to break it into 20-minute increments if we're doing a traditional CBT session. So the first 20 minutes is where we set the stage. Every CBT session starts with setting an agenda. You never want to start the session by saying, how's your week been? Because then you spend the whole session doing that. You start it with, what we're going to talk about today is, and then you list all of the things that will be covered. So you already set the stage that this is going to be highly focused and structured. We want to talk a little bit about sort of current stuff that's going to be affecting the discussion for that day. So what has happened either that day or within the past few days. And then you want to begin by taking a detailed description of their use for that past week or since the last time you saw them. So we're modeling logging, which I'm going to talk about in a minute. And then you review any previous practice or homework that you assigned from the last week. That's the first 20 minutes of every session. Then you move into kind of the meat of the CBT session, which is where you introduce a new skill. So this is where it's designed to really talk about the rationale. This is what it is we're going to talk about today. This is how it's going to help you. This is why it does what it does. So it relates specifically to their current situation or symptoms that they have just informed you about in that first 20 minutes. So that way you make it really salient for them. We want to use concrete examples, and then allow time within that middle 20 minutes to practice that skill. It's not sufficient to just give it to them and hand them a worksheet. We really need to make sure that what we're doing is introducing it briefly, going over the rationale, tying it to their current situation, and then saying, okay, now let's practice, because we want them to really have the benefit of doing it with you, so they can make sure that they're practicing the skill correctly when you assign it for practice over the week. Then the last 20 minutes is where we check for understanding. So this is where we want to make sure that we do some teach back, where we ask them to tell us, what they've learned today, and make sure that they fully understand the lesson that we've gone over. We want to identify any high-risk situations that could be coming up over the week, and you do that at the end of every single CBT session. And we'll talk about a little more detail, and I'll show you a practice sheet that you can use for high-risk situation planning. And then you schedule what are they going to do in between time. Why CBT tends to be so effective within a relatively short amount of time is because it emphasizes work in between sessions. That when clients or patients are doing the practice daily, they're going to make significant behavioral change a lot faster than if they're only doing it that once a week or once a month when they're having the discussion with you. So that's a traditional CBT approach. Regardless of whether you're doing a 60-minute session or you're just going to use some of the techniques that I'm going to talk about today, there are some challenges to utilizing CBT. One of the things that I think pitfalls that we tend to fall into is really holding ourselves accountable. We're expecting them to be structured and focused, but we have to have that same expectation of ourselves, that we don't get sidetracked or that we don't get pulled into sort of chit-chat or off-task behaviors. We also have to kind of problem solve in the moment the issue with doing practice in between sessions. So getting really good at using Socratic questioning or problem solving to figure out what might be the barrier as to why they're not practicing in between. Not falling into old patterns, and this is particularly difficult if you've worked with this person for a long time and they're used to a certain way of interacting with you, and now you're switching to a completely different style that has a lot more structure to it. That can be difficult, and we are likely to fall back into those old patterns. And then making sure that we're not being overly mechanical. We're also listening to what's going on, but we're balancing in that with really a teaching style. And we want them to walk away from that session with a new skill or with something specific that they can then apply to their life in an effective way. So some general things to keep in mind when doing any kind of CBT. It is important to honor this, that practice, practice, practice. It is so important that what we're trying to do is help someone change deeply ingrained patterns. We want them to learn new approaches and actually start to implement them. Understanding and insight is usually not sufficient for behavior change. The people actually have to start doing those things and have some successive approximations of getting closer to the behavior that they want or that they're saying is their ultimate goal in order to have sustained change. There are a lot of difficulties with changing someone's thinking. And so we want to be mindful that some folks are going to move faster than others, and that depending on the types of drugs that they've used or how long they've used, memory could be impacted, their cognitive ability could be impacted, and we have to make some modifications for that. That basic concepts should be repeated over and over again. Don't be afraid just because you've talked about it once that you shouldn't talk about it again. That a lot of the manualized approaches for substance use disorder, really any of the disorders that CBT is used to treat, will repeat the same basic approaches that we're going to talk about here in a minute, and just show it in a couple different ways. So that way we can attend for the different learning styles that patients usually present with. And that it's okay to repeat whole sessions, parts of sessions, or specific interventions as many times as you need, because what's important is that the patient learns it and that they apply it. A couple other things that are important to understand: whenever you're doing any kind of CBT intervention, you always have to link it with a rationale. You want to be clear why they should do this or why it is going to help them. That if we don't stress the rationale and make it clear, it's very unlikely that they're going to apply it. And you think about that with your own life, right? If my doctor tells me just do it because they say so, it's going to be less impactful than if they say, you know, this is what I suggest and this is why it would be helpful for you. And then you can make a clear, informed decision to take advantage of that skill. So if you're doing CBT, you have to make sure you're always providing the rationale for every single intervention. Also, a big piece of this is monitoring. The good CBT always includes some form of monitoring. That's why in the first 20 minutes, you check in with their use behavior and you get that, that detailed information. And we're teaching them how to monitor. And you can do this with symptom instruments. You can do this with use logs. You can do this in a bunch of different ways, but we can't see if behaviors are changing if we're not tracking those behaviors. So monitoring is really important. And then making sure that we're praising approximations, that oftentimes people will bite off more than they can feasibly do. And so we don't want to set people up for failure. We want to set them up for success. So when planning homework assignments or practice assignments, regardless of what they bring in, we praise that. Like we don't want to get into I'm the teacher and you were a bad student. We want to get into, hey, you did something and that's awesome. What would you like to try this week? Right? So we're always helping people to gain confidence and to have a really positive approach to the changes that they're making. A couple ways that we can think about doing that is making sure that you're not partnering with the avoidance, that when someone comes in, the first thing that you talk about is, hey, tell me what you did over this past week, or tell me about, let's look at your practice since the last time we met, that we don't want to forget to talk about it. It's just as important because if they didn't bring it in, they're not going to bring it up. We also don't want to fail to implement what we have talked about, right? So making sure that we're not avoiding it is important. And then we make sure that we leave time in the session to practice. This is just an example of how to praise approximation. So when someone comes in and says something like, I couldn't do the assignment, I was really busy, you just say, I totally get it. I understand, life gets really busy. How do you think we could make this assignment easier so that you could work on it today or tomorrow? Or how do you think you could shift things in your life to prioritize this, right? So it's just not partnering with it, not allowing that to stand on its own, but also not getting into that a wrestling match where we're kind of arguing with them about it. We're just trying to stay solution focused at all times. Okay, so now for the next 10 minutes, I'm going to walk through some specific CBT relapse prevention interventions that could be part of a larger CBT program, if that's what you're using, or these could be sort of standalone interventions that you might use as part of your whatever your standard of care is at the moment. So the first thing that we do under the CBT umbrella and relapse prevention is helping patients to understand what triggers are and how to manage them when they show up. So triggers are those things that sit outside the CBT system, right? So that something happens in the environment that cues up that thought, and then that thought is partnered with usually a physical, emotional craving, which then leads to use. And we know that this happens via classical conditioning. So most of you are probably familiar with Pavlov's dog's experiment. So that's essentially there's an unconditioned stimulus that gets partnered with a neutral stimulus, and over time it elicits the same response. So we know that that's happening when people are using drugs. So there's neutral stimuli, stuff in the environment. That could be money, it could be foil, it could be cotton, it could be anything that is partnered with the drug that by itself is totally neutral, but because it's been linked with the drug and the effect of the drug, it will elicit the same craving to use, or sometimes even the physical sensation of pleasure. That dopamine pathway gets triggered, even just engaging with the trigger itself. So we know this is really, really difficult for folks out there in the world because there are so many things, hundreds of things that get linked over time with their use. It could be particular streets, it could be people, it could be phone numbers, it could be behaviors, it could even be emotional states, so feeling really bored or feeling really sad. All of these things could be linked, which are going to then cause an urge to use and later use. So teaching patients this connection is a really powerful intervention. How we can start to do that is doing something called a functional analysis. And what this does is it walks patients through what are external triggers and what are internal triggers, right? So who, where, and when might you be engaging with in terms of use? And then what's going on inside? What are you thinking? What are you feeling physically? What are you feeling emotionally that might be connected to your use behavior? And then how much do you usually use, all of those things, the behaviors themselves, and then helping them walk through both the short-term positive consequences of their use, so that's the why, and then the long-term negative consequences, that's the why not to, right? So something like this, and there's all kinds of these, you could just Google functional analysis and come up with a bunch of different worksheets that will help talk to a patient about identifying what their triggers are and then how they're linked to their use behavior. Behavioral contingencies is another one. So this is teaching patients what are the things that are basically reinforcing their use and how can they start to reinforce differently. So we know that people respond to consequences and rewards, and that's been very clear, right? Rewards will increase a desired behavior versus punishments or sanctions will actually decrease it. We do know, however, that the effect of reward is a lot more pronounced and longer lasting. So in terms of what we're teaching, both in our clinics and what we want patients to start to think about is they are rewarding their self with their use patterns. So how can we start to shift those rewards so that they're still doing a behavioral contingency, they're still rewarding a behavior, but in a healthier way, with something that is going to be more either pro-social or pro-health instead of the seeking or ingestion of the drug. But we don't want to encourage people to just go without, we want them to do a substitution. So that's really what teaching a behavioral contingency is. So these are some of the targets that you could work with your patient. So what would you like to target? Is it maybe coming to your appointments, or is it maybe avoiding use? And how could we sort of reinforce that? There are a bunch of different ways that you can do it in-house, like sort of as part of your overall program, or even something as simple as saying like, I'm so glad you showed up today. That's great work. That's a reinforcer. And talking to them with their family, how can their family reinforce certain things for them, so that when they show up every day that they don't use, there's something that reinforces that. This is a tool that you can talk with them about to identify things that would be positive reinforcers specific for them. So what might be the situation that would come up, right, that would be a positive consequence, and then what would be an alternative that would elicit a similar positive consequence to use. So this is where you can make it really specific to their life, and you can have them walk through things that are coming up over this next week that are going to be triggers for them wanting to reinforce themselves with using, and then what could they do instead that would be as close as they can a positive reinforcer but not using. So this is a way of having them write that out and basically develop a plan, alternatives to use for that next week. And I would do this really specifically and just for a week or 2 weeks out. I wouldn't do this in general because it's not going to be as useful. The next one is urge management. So once we've taught people about their triggers and what's going to elicit an urge, now we need to teach them a set of skills to manage those urges when they show up, because they're going to show up, right? So helping them to recognize that these are short-term experiences, and that they, sorry, I don't have a slide on that. These are short-term experiences that are not going to last a long time, and that they can essentially just ride it out. So this is where we can help them write down sort of things that they can do to distract themselves, things that they can do to visualize in their mind that the substance that they're wanting is maybe toxic, or that the syringe is filled with bleach instead of heroin, or that they can call a friend in that moment, or that they can go for a walk or do something more enjoyable just to get through that urge. Because essentially what we want them to understand is that this is very time limited, and that if they can just get get through that moment, the next time the urge comes around, it's going to be less intense and it's going to be shorter in duration. And so every time they sort of surf that urge, or they postpone giving into that urge, the less intense those urges are over time. And so they sort of start to erode or dissipate as they continue to avoid them effectively. So there's a whole, I have a worksheet that I can send you guys. It has a bunch of examples on teaching patients how to manage their urges. The next one is logging, and we talked about the importance of monitoring with CBT. So we really want people to start doing this day one. They need to be, why is this got, why am I now? Oh, I'm looking at the wrong thing. Never mind. I confused myself. There's a couple different types of logs that you can use, but this is really just a core skill to help people first and foremost identify what and how much and how frequently they're using, because we can't help people start to decrease if we don't know sort of their baseline. But then once we're there, to help them start to tie it to triggers. So you can see on this one we've got the time, the date, the substance that they're using, the situation. So this is sort of tied to their triggers, and then those thoughts and feelings that are experienced when using it, and how you could even add. So with this one, coping behaviors. So this connects it to that. How are you managing the urge when it comes up? So the logging can serve a lot of different purposes. It can help them to really start accurately tracking their use, but then connecting it to their triggers, and then also connecting it to the things that they're doing to manage those triggers effectively, or maybe not doing effectively, and that will help them to identify patterns over time. So the logging is a really important thing. There's my urge circuit. I had it in the wrong, it's in the wrong section. Okay, here we go. So helping them to deal with the cravings, write it out like a wave, identify and label the craving, help them control it. Okay, lastly is high-risk situation planning. This is part of CBT that you always want to end with. And so I can't encourage you enough, if you do nothing else that we've talked about today, if you could tack this into every meeting, the last 5 minutes that you have with your patient, this can be super helpful. So you think about why everywhere that we work has an emergency plan, and we have to live through those silly fire drills. There's a reason for that, right? That if the worst case situation happens, you need to know what your emergency plan is. You need to know how to manage it effectively so there isn't chaos and people don't lose their lives. So all we're teaching them is to start to think about their use behavior that same way, to help them really start to identify what they can do effectively when they're in a situation that is really going to overwhelm their frontal cortex and put them in direct risk for using, and probably using in a really unsafe way. So what we're going to do here is help them to identify what's a high-risk situation and what's a low-risk situation, and be able to apply those concepts to their general life. We want them to begin to decrease time in high-risk situations and increase time in low-risk situations, so that they can avoid those easily. This is a general worksheet that you could give to a patient at the end of every single session, and just talk through, say what's coming up over this next week that could be a potentially high-risk situation. So this is going to be specific to them. So you can say, well, I have to go to a birthday party at my cousin's house, and I used to score for my cousin, so I know that he's going to have stuff on him when I'm at the house. Okay, how can you handle this situation? Let's work through 3 different plans at a minimum. Plan A is I don't go to the birthday party. That's always an option. Plan B could be I go to the birthday party, but I bring somebody with me who is never going to leave my side. So that way I'm not ever going to be alone with my cousin. Plan C is I have my sponsor or my good friend on speed dial, and I call them the second I start to crave, or I start to think that I'm going to want to go use. So you walk through different plans, so that way they have some flexibility in that situation. And then you can have multiple situations that are coming up over the next week to really teach them the skill of being able to plan what is coming down the road and what they can do to manage it more effectively. We really want this to be a daily to weekly sort of focus, so that way that they can start to do decreased time in high risk and increased time in low risk situations. And I cannot underscore the importance of writing this out. with them that is usually not sufficient, especially people early in recovery, to just talk through this. That they really, just like how we have a written crisis plan or safety plan, we want to have a written high-risk situation plan that they can keep on them, that they can really think through, that they can read before they go into that situation, because these are new behaviors that are not going to be easily accessible in the moment when they're having really intense urges or cravings to use. Okay, so that was a quick and dirty run through of some specific CBT skills that pretty much anybody could apply.